this is part 1 of 2. It's not next week, but the following week is when I come back. And I know through the behavioral health, you might have heard some of this, but I'm not sure if it's the same audience. So I'd like to call today's talk The Current Conundrums in Gender Medicine. So hopefully by the end of this, you'll be able to understand some of the basic terminology and therapies that are used in gender medicine, know how to screen and refer a young person who's gender expansive to community resources, to develop a practice that's more gender expansive and inclusive of our patients, and to be able to discuss general parental concerns regarding gender medicine. So what do all the terms mean? And the main thing I really want to emphasize is that the vocabulary is changing all the time. So trying to keep up, I think, is difficult. You know, with each generation, they have new words, new hip terms, and what gender means for them. So the best person is to ask, is the person who's using it, and to say, you know, what does that term mean for you? Especially, which we'll talk about later, the term like non-binary, I always ask, what does that term mean for you? Because it's quite variable. But just to make...
Sorry, doctor, can I go ahead and launch the pre-test really quick? Sorry.
Oh, yeah, sure.
We forgot.
There's a pre-test.
Yeah, and then we'll do it again at the end one more time. We still have a couple people coming in. Sure. I'm sorry to interrupt you.
Those who come later, they haven't heard what the answers are, so there's no advantage, disadvantage. This is interesting. I get to see it live on how the poll is going.
Yeah, you and I get to see. And once Dr. Maxim lets me know she's done, she'll get to see it too.
And is that for all 3 questions or each one?
Yeah, all 3.
Okay.
So the host will see, and then we'll run it one more time at the end, so you'll get to see the change. And we're just about 60% done, so we'll give it another minute or so.
So yeah, throughout the time, feel free. I think I just made it so that it would be enough for the time that we have been allotted with questions. So I'd like to make this be informal and to welcome people to ask questions as we go. And I will use Dr. Maxim's lead on if there's any questions.
Perfect. And I'll give it a few more seconds. Okay, all yours. Thank you.
All right. So we were just starting on terminology and to get some basics down. So I like to start to talk about, you know, what is sex, as in what gets designated male or female at birth, and typically it's based on physical anatomy, sometimes on chromosomes. It's what makes being a kid's hormone doctor or a pediatric endocrinologist exciting, because we get called when there are cases that might be difficult to assess. But that's not the main part of gender and gender identity. There's gender expression, which is all about the external expression of whether you're masculine or feminine or somewhere in between, how one wears their gender. So deciding what you wanted to wear this morning had to do a little bit with gender expression, maybe how your hair might be, if there's any makeup, anything like that. Then there's also gender identity, which is the internal kind of deeply felt sense of being male or female, or even somewhere in between. And it's really what you know in your head of who you are. And then I'd like to divide the next 2. People had known this more as sexual orientation, but I think of it more as romantic attraction and sexual behavior, because the romantic attraction can be someone you might have a crush and think about in long term, and then sexual behaviors who you might be partnered up with in a pleasure activities. And so the other terms that usually come up when you're seeing kids who are gender diverse is that people talk about gender dysphoria. So dysphoria actually has to be more about the psychological distress that is caused by the incongruence between what gets designated at birth and one's own gender identity. So you could have people who have a different gender identity from what got designated at birth, but may not necessarily have gender dysphoria. And others can have dysphoria, like chest dysphoria, as in my chest gives me a lot of dysphoria, but not necessarily about gender. The term cisgender is another one that people hear. And what that means is that the gender identity aligns with the sex that got designated at birth. And transgender is when, of course, the gender identity does not align with the sex that got designated at birth. And really, this comes from, I think a lot of people here might have taken organic chemistry back in the days. And it really comes from the Latin terms on the side of and on the other side of. So trans and cis sides of the chemical bonds. And honestly, that's about as much of organic chemistry that I used after the college class. So in young people, I'll use the genderbread person. Some people use the unicorn, and really is to help our younger people understand what we're talking about, of what's in their head, what they might feel in their heart, what they're wearing in their private parts. But around age 8 or 9, when kids are starting to understand about ranges and a spectrum, because in numbers they've learned there's positives and negatives and a zero in the middle, we like to go through this gender abacus with our patients who are coming in to ask them what is the designated sex at birth, what is their gender expression, where does their gender identity lie? And then, of course, I'll use 2 separate lines for romantic attraction and sexual behavior depending on their age. And sometimes it's good as someone is exploring to repeat this exercise with them each time. I think back in the days, we used to think, if you were designated male, then things had to line up on the other side and, how it all lines up. But I found that it could be a step case, it could be a swirled, and it can always be changing. And that's really important. Because an identity that we have to come to realize also is gender fluidity, or what it means to be non-binary. So that can mean that sometimes a person identifies as girl, sometimes as boy, sometimes as both or neither. And so really, when someone says I'm gender fluid or non-binary, I really like to ask them, and what is their expression, where they're leaning, and what would help with pronouns and whatnot for them. So how do you even talk about this? Like, when is it the perfect time? And as many primary care providers, I would say is whenever it comes up, is to be able to talk about it. So if it should come up naturally in your offices, then absolutely take that moment and say, I heard you. And let's, spend some time for talking about it. And typically it might be as you're leaving the door, it's like the positive door sign. You get the doorknob and you're supposed to go, and they say, oh, excuse me, just one other thing. I just wanted to reveal to you that I'm thinking about my gender. So you may have to have someone come back later to be able to talk about it. And at what age should I start to screen? What's interesting is that as our generations are learning about the vocabulary in school, I would say that most of our elementary school patients really know about these terms and what non-binary and transgender are. Whereas when I started this maybe 6, 7 years ago, it wasn't as a common everyday language. But most people would say definitely by 12 in our hospital, that's our practice for doing an interview for all visits without the parents to be present. And definitely around age 9 or 10, sometimes that is starting to come up as well. And you'll see how we subtly sometimes give hints and opportunities for us to be able to have these conversations. But from a developmental standpoint, so that you can take it into context, just thinking about, how does gender identity start and develop? So it's around age 2 or 3 that we've talked about when a child is able to learn what is male and female and then starting to identify their gender afterwards. I know that's what gets published, but some of the caveats I think that are important to remember is that until you're 2 or 3, you can't form formal sentences and talk, right? Like that's one of the milestones. Can you string 2 or 3 sentences together and be able to talk? The other caveat I think will be is who our role models are. Less than 50% of families now are made of what you might have thought traditionally as someone designated male and designated female and having a 2-parent household. Since that's no longer what you think is a typical family, as we have 2 fathers or 2 mothers or 2 parents in households or single parent, then who the role models are and what the roles go with the gender may become a lot more fluid. And with that, I wonder if gender identity is going to be not so distinct at this point. Now, everyone goes to kindergarten, and kindergarten is one of my favorite ages. And I say, if I retire as a kid's hormone doctor, I'd like to be a kindergarten teacher because the children just have such magical thinking, right? They go to school and you ask, what are you going to be when you grow up? I'm going to be the dragon slayer who is in a beautiful pink gown with a magic wand, etc. And they really think that's what's going to happen. You get to kindergarten, and those who have been affirmed at their home in the gender that they identify really think that when they grow up, they're just going to be that gender. But when you get to school and realize there's a whole world outside of your home, and that world may start to say and question some of your identities and just what you believe in, that's when some of the first time that there might be some distress that comes up. The other thing about kindergarten I always talk about is the kindergarten bathroom buddies. I don't know how many people have them, but I know in kindergarten, I guess they worry if the bathroom is not typically in the classroom and they have to go outside. At least around here, you take a bathroom buddy with you to make sure you don't get lost and come back. But the bathroom buddy gets bored. And so what does the bathroom buddy do while they're waiting for someone to use is they kind of look under the doors and they say, oh, they go home and they say, I saw so-and-so use the bathroom and I looked at their feet. And you kind of think about it depending on your gender and how you use the bathroom. And I saw so-and-so's feet the opposite way of what I thought they would be in the way they go to the bathroom. And that's how sometimes some of our patients get outed about their designation at birth versus their identity. But after that first year of kindergarten and they're starting first grade or so, that's when children realize that some of their magical thinking is more of a fantasy, and that there are certain things that make someone grow up to be who they are, and that one's gender is likely to remain constant and they're not going to grow into the gender that they identify as. But it's not uncommon for our children, about 12 to 27%, to be initially diagnosed with being gender variant at this young age because they'll display a lot of the characteristics of both gender. Unfortunately, some people, just due to the pressure to conform, will have to conform to the gender they've been assigned. Some of it is a natural progression in which they notice, okay, these were my feelings about how I thought, but then as things go on, this is how I identify myself. And some will later on identify as gay and not necessarily transgender. So from time to time, as people have looked at kids over time, 2 to 4% of boys and 5 to 10% of girls with their initial designation at birth behave as the opposite designation or the opposite sex from time to time. This is about 30 years old, and I think if we redo these studies, it might be quite different because we know that right now the presence of gender variant behavior is a lot more common, such that the prevalence is now about 0.7 to 2.7%. And I still feel that's quite variable based on where you're living too and what communities and cultures allow someone to be able to express that. So for each state and community that you serve, it might actually be higher. So what happens to people, as they're developing to know who stays and who doesn't stay? So the persistence into gender dysphoria into adulthood, you think of those who are more gender variant behavior during childhood. So someone who expresses from a young age does not want to wear the clothing that has been stereotyped for their designation, but they really have this intense uh, advocacy of who they are since childhood. And they're very persistent about it. It doesn't go away. It changes, people think, will it change? And it doesn't change. And it continues through their elementary school years into middle school and even as they enter high school. So it's been coming to be very persistent. And some of the children will correct and say, I am of the other gender. It's not I wish to be, I am. And perhaps you're the one who has a confusion. This usually happens in our kindergartners who really go around saying, but I am a boy. I'm not sure what you're talking about. Now, this is, what I'm talking about in someone who is identifying and affirmed as a young age. But the caveat I really also want to make here is that some emergence comes later in adolescence because the terminology is not known, or they've been just thinking about it in their head and not sure and figuring it out. And then they say, this is what it means, and I'm learning of who I am. And sometimes it's not till adulthood where the identity is truly expressed. But that does not make someone be less transgender than another person because they came out at a later age versus someone who comes out at an earlier age. And I do want to emphasize that. So the three terms that our mental health providers look for, and the answer to question number one was whether someone has been persistent, they had been insistent and consistent in their gender identity. Those are the people who tend to carry their gender identity throughout their lifetime. This is all because of social media, right? How many parents come and worry that this is just a trend, it's going to change? One of the things is, it's really stressful to be transgender or gender diverse. And the attention that you're getting is a lot of negative attention, even though it might be attention. So I find it really hard that a lot of our patients just do it to get negative attention and to be more stressed than they already are. So it's true that through social media, you can make friends and learn about terminology and help you decide and come up with terms that fit for you. But it's not that just by watching the social media, that's what made someone to be transgender. So the other thing that's also known is, why are we seeing such an increase? Part of it is because you can talk about it. It's now not uncommon to have formal gender clinics. When I was training, many years ago, we always had gender medicine, but there wasn't a formal clinic. I just knew that where we were, and I was in Boston, that there was a clinic that happened on Saturdays and people showed up and they got treatment. But there was no sign that said, pediatric adolescent gender clinics. But now there's formal ways in which people, and for better reasons, are monitored. There's a protocol and people all follow like the plan for it. Gender identity is also part of the vocabulary. Like I said, in elementary schools and whatnot, the children and the youth really know about identity. And I would say, I'm not sure if you've noticed this trend, particularly in the state of Hawaii, if people are comfortable not only talking about male, female, transgender, non-binary, but just even culturally about the third gender and perhaps being mahu, if that has become more common and accepted as well. And new knowledge about gender is just developing and recognizing that there's a lot of overlap and it's not just two very opposite terms. And of course, the last thing is it's not contagious. Parents really worry because you have a friend who's transgender, now you're going to be transgender. And I say, well, when you were cisgender, did that make you have a friend who was cisgender, make you be more cisgender? Or if someone was gay, did that make you want to change your mind? So just kind of putting it in that context. So we know that the prevalence is between about 0.7 to 2.7. But when you go back and look at DSM-5 codes, the numbers are really small. So people say it's just a, a pandemic, an epidemic. It's just increasing. What's going on? I think just to take a moment to realize that when the DSM-5 numbers were provided, first of all, it was more than decades ago. And it was really meant that when a time there was no formal gender clinics, you had to have an adult who felt comfortable to say, I am identifying of a different gender than what I was designated, and I'm going to go to the doctors. And not only am I going to go to my doctor, my PCP, I'm then also going to ask to go and see a psychiatrist or psychologist and talk about it. And then I'm going to be given a diagnosis. So of course, these are like really underestimated numbers and they're super small. So when you compare those numbers to what we have today, it seems like the numbers are just increasing and increasing. The new Gallup polls, however, in February of 2022, because that's when they always give out the data, and shows that 7.1% of US adults identify as LGBT. And that only goes to LGB and T, so the other identities are not on there, which is a considerable increase from 2017 in just 5 years. And when you talk about the Generation Z, and that doesn't even include the kids currently in elementary schools and junior high schools, 1 out of 6, so almost 20%, are identifying as LGBT. And so what I like about the way they've done this from the Gallup poll, if you look at it, is based on the time in which you were born. You can look at what percentage was back in 2012 and 17 and 2021, and then they give the data, publish it in 22, to see who are identifying as whether LGBT. And if you go into their website, you can even see specifically what percent is going to be identifying as transgender, lesbian, gay, bisexual, etc. And so the highest right now is, of course, the Generation Z, which was a question that was alluded to in the pre-test. But seeing how the trend is just going up. So the other thing this must be a trend, is when Christina Olson, who's done a lot of this work in following our population of youth and really done through the Gender Development and Trans Youth Project. Dr. Olson is now at Princeton and had been in Seattle. So the mean age was 8.1 years who were allowed to socially transition, and then they were followed for 5 years. So to socially transition meant being able to use name, pronoun, and dress that aligned with their identity. There were 318, and 208 were trans female, and only 7.3% retransitioned once during the 5 years. So what that means is they went back to the identified, not to the identified gender, but to what was assigned. So if someone was designated male at birth and had expressed as female and used female name and pronoun, 7.3% actually went back to being in the male gender. At the end of the 5-year period, 94% actually stayed the same as the binary transgender. So if they were identifying as female and then said, I want to identify as male and I am male, 94% continued to do that at 5 years out. 3.5% were non-binary, and non-binary, we know, may be possibly a temporary term, or it may actually be just the identity. And then 2.5% were cisgender, and those who were going to transition or retransition back, what happened was they were typically less than 6 years of age when they initially socially transitioned, and if they were going to retransition, it occurred by age 10. So as you're in clinics and you're going to be seeing the transition and the retransition perhaps in the smaller percentages, how can you make it an environment that's going to be more inclusive? First of all, I think is education of all our providers. That's one of the things we love to develop for everybody. And so in our clinics, it's not just the providers, but making sure our front desk, the medical assistants, the nurses, the phone call people, everyone is up to date on gender identities. And providing opportunities for people to be him, her, or themselves is super important. So on the forms, just ask as what's your given name? What's the name used? What's the pronoun used? And for some of our boxes in our written paper, although we've become more and more electronic, and I'll show you, he'll say male, female, and for the longest time we had a line. I think almost everyone thought it was just a typo. We had this ugly line, but for someone who's really wanting to transition and make it be known, that was an opportunity for someone to write it in. For our staff, we always like to address people as Patient Smith, which is like the last name, or Parent Smith, when you're not sure, and using gender neutral terms as parent or guardian, depending on what the relationship is. And that way, you don't assume. I think one of the things that we want to make sure is if you see one child with another one is asking, if you have someone who's expressing as male and they come in and they, you don't want to say, oh, is mom coming too? But it should be, is there another parent also joining? So those are things that help, and Smith being just a last name. The way I like to do to kind of help and open the door is when I go into the room, I'll introduce myself first so that the onus is on me. I'll say, hi, I'm Dr. A. I use she, her pronouns. And then I will ask, what name do you use? What name do you go by? And what are your pronouns? That totally just opens it up. And I do this for all my patients. And I also give an opportunity for the parents. It's like a litmus test, because if the child or youth is like taking a moment and it's like, oh, I want to use this and whatever. And if the parents are very comfortable with rolling out with name and pronoun, you already know that this is a family who's a little bit more up to date about gender identity, and pronouns. And the reason why it's so important that we're very inclusive is when we look at the data, a lot of our LGBT community members really feel that they are discriminated against when they go to seek medical care or attention. Almost a quarter of trans feminine individuals report that they were less likely to get preventative care because they were really worried about being discriminated. And in fact, a quarter to almost a half said when they actually have gone to seek care, they actually did experience the discrimination. And the percentages depended on the health setting, whether urgent care, emergency, or just your regular routine checkups. And so the people who were surveyed here reported that they were 20 times more likely than those who were not LGBT to actually seek medical care until it's almost reaching a point in which you have to go because you're in so much pain or you're so sick. Then they're finally going to go because they're so worried about discrimination. So in looking at pediatrics, just kind of saying, okay, maybe that was more adults or young adults, but what about the kids? How do they feel? They found that the trans youth also said that they're probably not as healthy and their health was worse because they didn't want to go and seek preventative care than their cisgender counterpart because they were worried that the doctors wouldn't understand. So it makes it even more important that if you get a patient who trusts you and identifies and discuss this topic with you in an office setting, that what an opportunity that they're trusting you, and to remember that and to take that opportunity to have more discussions. We can also have a welcoming environment, and really in the books that you have in the waiting room, the decorations, really being more inclusive is important, and really having art that encompasses diversity and giving opportunities for patients to talk to you and listen are all what we can do as providers. And it has to go beyond the clinic. So some of the things that we can do, I know when I started this clinic for us at Stanford, is we started having awareness, because it's not just of the people coming in, but people who were already there. So it was the first time in which we had the LGBT Q Plus forum. Now we're entering our 4th or 5th year. Just with COVID, we had some different ways to do it. And this year is called Celebrating Queer Joy. And it's just having a lot of artwork and music and celebrations. So it's been a great opportunity to allow people to be themselves. And by having role models and noticing that in your clinic you have these role models, it's going to allow people to want to come and feel comfortable in seeking care, and also becomes a resource. Like, you can be a resource for others who are learning how to seek care, and then the effect can go on. Collecting the data to help with identity is important. For us, we use Epic. I know Epic is meeting with us to do a lot of this rollout, and each institution's Epic may use something like this. Ours was a little bit custom built, but we really have our what we call GISO, but I think Epic is now calling it SIGN because it sounds nicer. So it's going to be sexual orientation, identity, gender. And so talking about what pronouns are going to be using, what gender identity, what you were designated at birth, and then the steps that have been taken. So these are available for us, for all MDs, nurse practitioners, and nurses to fill out. Patients who are registering can also fill this out for themselves as well and be able to complete it, so that when they come, we know. There's also another area for them to complete their name, and so that we will know what name they're using. Once you have more of an intimate, behind closed doors, and you're able to talk with your provider, the primary care providers, gender team, surgeons, any actually NPMD has the ability to kind of complete the rest if they want to share this information. So we have it in that way, at least for the first part. It's something that pops up, in which we have as a reminder. So anytime you're going to go into a chart, the name used would show up. Of course, for HIPAA reasons, I have it blacked out here, but the correct pronoun, their gender identity is there, and you have to physically acknowledge it. And only by doing that, the box goes away. So it's just a reminder to get it done correctly. Interestingly enough, where it says remind me in 24 hours, some people want it to be reminder all the time, and some wanted it to be later, and our later is a default of 7 days. For instance, if someone is inpatient and they're in the hospital for a long time, the nurses found that they don't need to be reminded, every time they go into the patient's room to give a medication. But if they didn't come back and get the same patient assignment and it was like a week later, they might want to know that. So when the person discloses to you, what can you do? You can acknowledge it, like I said, and say, thank you so much for sharing the information with me. Is it confidential? Ask them, is it okay? Who knows? Does your mom or your dad or your parent or your guardian who's here knows? And what can I help you with? And you may not be able to talk to them right away, right now. And, you might have a whole room of people who are coughing and sick or that are waiting for you. But you can ask, are you safe? And is this something that we can schedule a follow-up to discuss further? I appreciate that you shared this with me. This is really personal, and I feel privileged to learn this. But can we talk about it more so I know how I can help you? And in the meantime, you can gather local LGBTQ plus group and nonprofits and gender clinic informations. And it's something that I am actually working on to help, including for the state of Hawaii, to have these resources be gathered and to be able to help. And then just listen to what the patients are telling you, and letting them know that you're not going to abandon them, because that's their fear, is because I let it out that I'm going to be abandoned and now I don't have a doctor. So letting them know, and I can continue to be your provider. I may not get it, correct, but at least I want to learn and be able to help you. So things that also come up, right, is this dual diagnosis one about, is this autism or is it really puberty? What happens? That's a common theme that we're starting to see. Yes, pubertal development can cause a whole lot of anxiety and uncomfortableness for a lot of people. But pubertal development doesn't necessarily cause dysphoria. Dysphoria in that you're not able to do your activities of daily living. So really seeing, is this really anxiety and you're fearful of what the changes are to come? Is it a hyper focusing behavior? You're just focused on, someone who's on the neurodiverse spectrum may just be thinking of, okay, these are bodily changes. Bodily changes come from hormones. I am making hormones. I'm going to get changes. What are the changes? Well, I know testosterone. And some of those patients are just very detailed oriented and they can tell you everything about testosterone. And then they say, I know about estrogen and I am not wanting this. So I might only want this hormone. But we really have to be careful to realize, is it really gender dysphoria or is this anxiety and hyperfocus? So a lot of studies have kind of looked at it to see, is gender dysphoria more prevalent in those with ASD? And the majority of the evidence that's available review is really cross-sectional, and they're done without additional clinical evaluation. So for instance, when you look at questions on an ASD screening tool, they're kind of confounded by symptoms of gender dysphoria because one of the things is asking about, what's your social responsiveness? And so 45 to 68% of young people with gender dysphoria are going to have autistic symptoms just based on the way in which the questions are asked. So for instance, has difficulty relating with peers. Well, that could be related to all sorts of reasons, right? It could be related to autism, that you have difficulty relating with peers. Or is it because of your gender and your gender dysphoria? It could be not even related to either one of those. And you could just be really introverted. So it's not a good question. But these are the scales that are getting used to make these diagnoses. Demonstrates a strong interest in gendered items associated with the opposite sex. We know that some of our neurodiverse patients may really be interested in a particular hyperfocus item. So perhaps it has to do with planes, and it's just thought that planes and automobiles and trains are, something that gets associated with those who are assigned masculine. And because you're assigned feminine or female, and you have these interests, people are gendering you. Can't get his mind or her mind over certain thoughts is another one. Repeated actions over and over. So therefore, just thinking that someone with gender dysphoria may have ASD. And so it's really important that proper evaluations separately are really done and thoroughly. And in fact, part of the new WPATH, which is the World Professional Association of Transgender Health, is requiring that this be something that is thoroughly explored and people who are doing the evaluation do understand the difference of autism versus gender dysphoria. So one study that was done from the Netherlands showed that there were 231 children who were referred for a gender evaluation, and they followed these patients in their medical record prospectively, and they were able to do that because in the Netherlands, there's one just medical system. 204 actually got evaluated, and of that, 108 children and 96 adolescents were identified as having, they called it gender identity and gender dysphoria, or NOS. And then there were some who actually didn't have this diagnosis. Then what they did is after 1 to 4 years after the gender dysphoria, they said, well, how many people actually have neurodiversity or autism also associated? And you can see that the conclusion in the report was only about 7.8%, which is a lot smaller than what numbers we've been hearing, is that up to a quarter to 30% of the patients have an overlap. So those with ASD have gender dysphoria. So really showing it's important for us to look at this more carefully and before we just put out percentages too. So what happens when you come to a gender clinic, at least in our clinic? I think we provide our patients with an opportunity to tell their story and to listen. Most are so surprised that someone actually wants to learn about their gender journey, their identity, how they got there. I'm really about meeting a family where they are. So a lot of times our families come because they've just learned about it. And they're just learning, they're bringing it in, talking together as a family. But they come with the fear that by coming to see me, I'm going to throw hormones at them. Here's going to be a book. They're going to be scheduled for surgery, and that's it. So a lot of psychoeducation, talking about the processes, allowing them to voice their fears, listen to their fears is what we end up doing. And, why are we providing the therapy and what happens? Unfortunately, we don't have a whole lot of long-term large cohort studies right now because most formal gender clinics are only 5 to 6 years old, but registries are starting here in the US. There are some in the Netherlands that are already done. Transgender youth who had been supported have the same rates of depression, anxiety, and suicide as their peers and their siblings, like also done by Dr. Olson. And 55 transgender adolescents who actually had rigorous psychological evaluation, exploration, evaluation for readiness, and then started medical therapy and were followed, had no regret of their decisions. This was in 2014, and the same cohort has been followed now. So another, I think when it came out was another 7 years later, they were still not having regret, because that's what people worry about, is the detransition and regret. And care may consist of just providing an affirming environment. So when they're first just coming here, it might just be that it's a place where they can be themselves and talk and listen to us from a medical standpoint. So does the timing matter? That was another study that got done. So looking at the association of the timing of transition, whether it's prepubertal, childhood, adolescent, or adulthood, and adult mental health outcomes, when a secondary analysis of the US 2015 transgender survey was looked at, and that actually had about 28,000 transgender people, so that's a huge number. 165 of those who completed the survey and identified in here said that they were transitioned up to age 9. About 1,200 were 10 to 17, and then the rest were majority greater than 18. So although the survey went out to a lot of people, not everyone, of course, completed the survey, but younger transition was associated with lower marijuana use, suicide attempt, and other adverse mental health, probably because they weren't trying to self-medicate or treat for perhaps some of the anxiety and depression and stress that had been caused. And then finally, in another study, what we did was we asked all the families that came in, and we talked to the parents separately and we talked to the patients separately, asking what are the moments in which you learned, which we called were kind of big milestone moments about your gender identity, talking to the family. And at those moments, how did a parent feel about their support and their acceptance? And what were the things that you wanted to do immediately for your family? And then asking the patient, what is it that they wanted to do? And our study found that after disclosure of their gender identity, what the adolescents wanted the most was for their parents to use the correct name and pronoun. That was number one. So that was, I think, question number 3. They were not interested in, immediately taken to a mental health provider or to a medical provider, whereas parents answered their number one choice was to get them to a doctor, because they just had to get them there and figure this out. Was this a medical diagnosis? And when you ask number 2, what the adolescents said that they wanted the most was a physical expression of love and support from their parents. So they said just for them to be there to listen and to give a hug or a shoulder to cry on. That was the most important thing. So when families come to our clinic and are terrified, I tell them, the number one thing that your son, daughter, child is asking is for you to use a name and pronoun. And you feel like, they want to do things that are non-permanent, reversible. What an easy thing that you can be able to do, because if a name changes, to change back to a name and a pronoun, that is non-permanent. And as a parent, we're trained to physically love and show expressions of love. So why not be able to do that? And when we asked, the adolescents actually rated their parents to be more supportive than the parents really rated themselves. So parents always kind of being harder on themselves. They said the support that they're getting from their parents was always about 1 or 2 points higher than what they had, what the parents would say they were giving. And it also shows that even those parents who felt like they were supportive and accepting, they were actually hiding the support that they really needed. And they really felt like they needed mental health, other people to talk to. And where do the parents and families find the support was from other families, not necessarily LGBTQ plus, but it just helped sometimes. Also, other family members who were willing to listen. Parent groups were important for shared experiences. Medical providers to be that source of knowledge to validate and address questions. And of course, our mental health providers were super important as well. So I'm going to stop here today as part one because we have 10 minutes for questions. In 2 weeks on the 19th for this cliffhanger, and hopefully you want to come back, we're going to go into details about all the different hormones. But at this point, I love to answer any questions that you may have.
Thank you so much, Dr. A. That was really informative, and I think a really good place to start for so many people who may not be familiar with a lot of the terminology and just the most simple needs. Maybe while people are thinking of their questions, we could do the post poll real quick. And there is one question in the chat that's talking about the use of last names. So maybe we can talk about that first, right, as soon as we finish the post test.
I think it's great. I did not know for European that the last names can be gender identifying, and that is true. I think some of our, that's where the cultural differences come in, and it might be for each of your cultural areas. There are cultures who have honorifics and it's not gendered. However, the way you're going to refer to a person is going to be with certain titles and whatnot. In fact, that's one of our research areas that we're working on in our NHPI. So Asian American, Native Hawaiian, Pacific Islander is one where we're looking at. I do apologize if I hadn't, this is not all, if it's all MDs, RNs, and sure, NPs as well. I think for us, we kind of had lumped them, but that's a great suggestion to be able to include our NPs.
Along the lines of this question of like naming and gender, can you talk at all about languages where sort of all the nouns have genders and people's like every single, like Spanish in particular, I'm thinking,
exactly.
right, where like every adjective is gendered, and it's like, I don't know how you speak Spanish without gendering adjectives.
It's interesting. When I started this, we had our Spanish interpreters who came and they said, oh my gosh, it's going to be so hard because we have to, put one or the other. And if someone has moved, it's easy. But if they're non-binary and in between. And then this is, I think, local. And I don't think it's like across all the different countries who speak Spanish. But as my son now entered high school and is taking it, they actually have a gender neutral. So instead of ending in O and A, for words, it ends in an E, and it's almost slang, but just keeping it neutral for the pronouns and the adjectives. So I don't know how that language got created, but they've been learning Spanish in a gender neutral term. And for the kids, in some ways, it's easier because you don't have to conjugate and remember that stuff anymore, and it's all gender neutral. So I think languages also evolve, and they had certain terms that they would use. But that's where I think going back and just asking the youth, what is the appropriate language? What adjectives do you use? How do you handle it?
Yeah, thank you. Any other questions, folks, that you wanted to ask?
I don't have a question, but I just want to say that was a fantastic explanation, especially of the different terms. I don't know, I feel dumb because no matter how many times I hear it, it doesn't stick, and I have to refer back and figure out what each of the different terms mean. So that was a fantastic explanation. Thank you so much. Are the slides going to be posted?
Yes, I will
Okay.
be sending them. I do have to give it in a PDF format
Yeah.
just for reasons that
Sure.
I'm having to abide by. But yes, I will send them out shortly after.
Thank you.
And we also record the sessions, so the videos are available on our website afterwards as well. And the
Yeah.
password is Keiki. So for any, if you want to drop the link in the chat, Summer, that would be helpful. And then the password is Keiki.
Yeah, so you know, Mr., Ms., Mrs., Miss, I think at least in the patient world, just trying to be without it, and sir and ma'am. And I think some people just say, you know, these are just really traditional terms. So I'm respectful of you, but we're just going to go by a last name or something. It's hard, and it depends on what the tradition is for, right? Like wedding invitations, that's one where people talk about, like in families, what's it going to be, and we're getting invited, how do you do that? Can you just say student? Can you say parent? Can you say you know, family member? So those are sometimes conversations that you just have to have, because these formalities that got created are really gendered, and I don't know a good non-binary formality term.
Maya, speaking about the languages that have, nouns that are, gendered, Hidden Brain just this week did a thing on that very topic. So go get the Hidden Brain podcast and listen to this week's episode.
On
You know,
NPR?
that's one I have on my phone, and I've literally never listened to an episode, so I will be inspired to listen.
Oh, I love it. So I'll have to listen. Thank you, Danielle. I want to listen to that. Yeah, to whom it may concern, I love it, Maya. Yeah, dear colleague, dear whoever is the person. So I think it's become more role than the assignment, right, of Mr., Miss, all those things. Very anti-British. They're all about their roles.
You know, and I think I saw something on Twitter actually just the other day where someone had like screenshot a letter of recommendation that said "Dear Sirs" and was calling it out as like, you know, hello, it's not only sirs that are receiving letters of recommendation. I think this was for like residency applications or something. So, you know, none of us, I'm sure, are doing that, but I think just continuing to gently remind people too when they make those mistakes. And maybe you could talk a little bit, Dr. A, about, you know, when you have people that you encounter professionally, whether learners or peers, you know, do you have like sort of canned phrases that you use to sort of call in rather than calling out, or sort of to educate in a way that doesn't feel like people are going to get defensive?
I mean, I think in role modeling of how we present our patients from the beginning. So when someone comes in and, you know, our third year medical students or trainees, right? They're so used to name is a blank year old blank. And I say, okay, that's one way to do it. And for us, we're a little bit luckier because our content starting first year medical school is really changing of using those presentation styles. And I know I'm going to be hopefully getting to work with some people from Hawaii on that. But it's just to say, is a blank year old designated blanket birth who presents for, etc. In terms of like writing letters and stuff, just saying like, dear program director, right? That's what the person is a program director. The other thing that I really role model that's important, I think, is anytime a mistake is made, and it's not just about gender, but in front, and you say, oh, you know, I apologize, I misgendered. I meant, you know, I used your wrong pronoun. And I'm sorry, but then I go right back and I don't sit there and say, oh, I should know better and I didn't, and, you know, let me talk about it. I know your pronouns. And because the person doesn't want to hear that for like 5 minutes either. And then to be able to go on, I think is another thing that's important to be able to do that. So where I think I still make a lot of mistakes in trying is in a room. People have said, hey guys, right? Like, or all you guys who are joining on, but that's not where the identity is. And that's kind of where. And so it's weird but you all is much better than guys or ladies, or because you is much more gender neutral, right? So all participants who are here, all the students, all learners, right? Kind of using those kind of terms when you're trying to call attention to everyone.
I
Yeah.
think that's a really good question. Oh, go on, Danielle.
I mean, terms like, yeah, like ladies and gentlemen, I mean, it excludes all the non-binary people. So things like that. And most of us, I mean, you know, if you misgender me, I don't take it personally. I mean, it's just like, you know, I've misgendered myself on occasion. So it's just, you know, it's just it's not a big enough deal unless I feel like you're really doing it repeatedly and intentionally. Then I take offense to that.
Absolutely. So the one question, you know, what happens when your biomarker has been changed, but your organs may be different? So let's say your biomarker says male, but you have a uterus. And I think our healthcare systems in the computer, you know, realm do not understand that just because it says M, you could have a uterus, right? The computer goes nuts over that. So things where we notice is like you try to order a mammogram and the computer's like, error, like you can't order a mammogram. Or you can't order, one insurance just denied me ordering oral contraceptives. They're like, this is a male, why are you ordering it? Denied. So I think it's really a matter of working with our computer systems. I know for us, if we have anyone who doesn't align with the gender that's identified and the legal one that's still in the record, if the two don't match perfectly, then as a provider, I have a choice of whatever, then it just opens it to everything. Instead of defaulting to nothing, it's open to everything and it's flexible, and I can order a PSA and oral contraceptive pills, like, because the computer just loses all algorithm, but that's something that has to be set up, right, separately. And there is ongoing research definitely of what's going to happen to processes. And in order to do that, having like registries of patients to be able to have that longitudinal data to know, you know, how sex hormones and different sex hormone exposures are going to impact the underlying diseases and conditions. We do complete an organ inventory for all our patients right there now, but still having that male with the uterus, it wasn't so much for Epic, I could order it, but it's the insurance saying, you got it all wrong, doctor. And I actually we have to do a formal appeal because the person who answers the phone says, you said, and you know, because they're just answering it on the phone tree, it just says denied. So that's been a fun one because I can't wait to get to the doctor who's the administrator. So I'm actually looking forward to that appeal. We do a lot of appeals at our clinic. I want to be respectful because it's 4:01 and this is till 4, right? Or is this long? Okay. But I'm back in 2 weeks and it's just going to be all hormones next time. So I hope to see some of you back.